that collectively received more than 4,000 citations. Such papers mainly focus on functional studies and the molecular characterization of germline mutation variants of clinically relevant cancers, include gastrointestinal, breast, head and neck cancers. Her speech will grant us with essential information concerning the germline variants associated with cancer risk and actionable drug targets. So let's all welcome Professor Silvia Rogato to talk a little about her contribution to this exciting theme. And thank you again for accepting our invitation, Professor. The words with you.
Okay, thank you so much for the committee that accepted my name to participate in this wonderful meeting, and in special thanks to Roberto for the invitation and for this strong collaboration that always is one very good opportunity to illustrate my collaboration with Brazilian colleagues. Well, therefore, it's an honor to be here and to present some data that I have in cancer, young cancer patients. Although we have substantial advancement in sporadic cancer and also in alterations in somatic events, the knowledge regarding the spectrum, frequency, and implications of germline alterations in cancer patients is limited. It's mostly related to the hereditary cancer syndromes. Então, based on this information, I will try to explain a little bit about the hereditary cancer syndromes. It's well described that around 10 or 5 to 20% of all tumor types has a hereditary component. And then in these cases, at least you know the gene that is associated with the high risk of the disease. In 5 to 15% of cases, we have a familial cancer when you know that there is a clustering of cancer in those families, but you don't know the gene related to the cancer risk. And we have the high number of cases is defined as sporadic. But right now, we also discussed the role of germline alterations in some sporadic cancers. And I will devote some time to talk a little bit more about it. Well, when you talk about germline variants in cancer, you always think about hereditary cancer syndromes. And the genes altered, or the genes that present these alterations in most cases could be null, or sometimes the patients or the family follow some criteria to fulfill the hereditary cancer syndrome, but not always they have the variant or the mutation associated with the disease. In general, we have some classifications of these variants according to the some guidelines that is used to classify those variants in pathogenic, likely pathogenic, or variants with uncertain significance, although some of those that you call of uncertain significance has some damaging effect to the disease. According to the time when the knowledge is improving, sometimes some VUS change of the classification and is considered pathogenic or likely pathogenic or benign, sometimes happens. And now we always think about germline variants as associated with targets for treatment. In opposition, when you talk about somatic variants, in general, we talk about molecular marks. They have predictive or prognostic impact in the disease. And also some alterations have been used to improve the treatment of cancer patients. This is a typical, or at least one typical family history or idiogram. when you can observe the individuals affected from 2 different families. They married here from 2 families, but you saw that this family has some history of cancer, and also this one has family of cancer. And then here we have colon and breast cancer at a young age, 40 years old. And then we have also patients with 3 tumor types: colorectal, breast, stomach cancer with 40, 43, and 44 years old. They are primary tumors. They are not metastases. They are also primary tumors in the same patients. These patients, I wanted to know if this patient has some inherited variant from this family or this family. The best way to identify this is to do sequencing and to confirm if they inherited some variant from this side or this side. But according to this history of this family history, probably the gene involved in the disease is inherited from this side of the family. But you just will have sure about it when you do the sequencing, just to confirm if they have or not have some variant associated with the risk to develop the disease. Well, we know some features involved in the hereditary cancer predisposition syndromes. One of them is the age of onset. In general, we have young patients affected by the disease. This is one main feature. When you check a family and you have some young patients affected with a disease, when the sporadic tumors occurs later on in the life of the patients, and then this is one first indication that this individual can pursue variants involved in the risk of the disease. We also have the presence of multiple family members affected with the same or related tumor types. It's also common the patients present multiple primary tumors after a first tumor developed at that young age. Well, to identify germline predisposition variant, it's a very relevant topic, just to identify the variant and use this variant for genetic counseling, for cancer screening, and also today, nowadays is used for treatment decisions. Some of them, according to the gene involved in the predisposition, you can indicate some specific treatment based on this variant. And also there are some strategies that could be adopted to implement the risk reducing to reducing the risk of the disease. Just like, for example, patients that present BRCA mutations, you can suggest or can indicate a mastectomy or oophorectomy for the family or individuals with the variants. We know more than 30 hereditary cancer predisposition syndromes. Most of them are autosomal dominant. They present penetrance incomplete, what means that patients can present the variant, but the probability to develop the specific disease could be variable. And then they have the mutation, but they can develop or not the disease in some frequency. This is the level of penetrance, is the measure of the proportion of the individuals that carry the mutation but can develop the phenotype. And most genes associated with these hereditary cancer syndromes are tumor suppressor genes, and there is a set of genes involved in repair also associated with these hereditary cancer syndromes. Two very common syndromes, cancer associated, is hereditary breast and ovarian cancer syndrome, where the gene is associated with the diseases BRCA1 and BRCA2, and Lynch syndromes, when they increase the risk to develop colorectal, endometrial cancer, and also breast cancer, and they are associated with mismatch repair genes mutations, MMR mutations. I will talk a little bit longer about this. This is just timeline when you can see the development of genes discovered across the time. And then we saw, for example, in 1986, it was discovered the RB1, tumor suppressor gene related to retinoblastoma, but also have been reported in other different cancer syndromes, just like osteosarcoma, for example, also can present mutation in RB1. But you have several mutations described across the time that characterize some specific hereditary cancer syndrome. One very common Brazilian syndrome is Li-Fraumeni. Li-Fraumeni syndrome is associated with TP53 mutations, and in Brazil, we have a high incidence of one mutations, PR337H, that increase the risk of the syndrome or to develop cancer in our population. We have the highest number of TP53 mutated individuals in the entire world. It's because one person, Portuguese one, disseminated the mutation during his travel in different states of our country. And now we have the risk to develop the disease is really high. They have different tumor types associated with the diseases, very common multiple tumor types. Li-Fraumeni is a huge and interesting cancer syndrome related to the risk of cancer. We also have other mutations, just like in colorectal cancer, mostly genes associated with mismatch repair, which promotes the instability of microsatellites. And across the time, it's possible to see the improvement of different methodologies to identify these mutations. Today, we use the next generation sequencing in panels or the whole exome sequencing or the whole genome sequencing to identify variants associated with the risk of the disease. There are some panels specifically with genes related to the main syndromes related to the risk of cancer when it's applying the clinical practice in different parts of the world. And then our knowledge about it is increasing a lot. Here, I'm just giving some example of a very rare tumor. It used to be really rare, but now we know much more about pancreatic cancer. For example, we have several cancer syndromes that has in their spectrum the presence of the pancreatic cancer. In hereditary breast and ovarian cancer, when the genes are related to the risk of breast and ovarian, but they are also are related to the risk of pancreatic cancer. We have BRCA1, BRCA2, PALB2, and RAD51C. Those genes increase the risk to develop pancreatic cancer in addition to the breast and ovarian cancer. But you also have in pancreatic cancer observed in Lynch syndrome, when you have MMR genes mutations, and Lynch syndrome is mostly characterized by colorectal cancer, endometrial cancer, and so on, but pancreatic cancer also is related to the Lynch syndrome. Therefore, what it means is when you have a family with sometimes is different tumor types, but they are somehow related, you can have different mutations related to the risk of those with that syndrome. Then it's essential to identify the gene associated. With this result, you can give the best treatment for the patient, and also you can also allow the identification of the mutation in different family members, and then the disease can be detected at the early stages and treated, and then the patient has high probability to have a better survival. Well, this is just to clarify that sometimes you have a tumor type and not necessarily is a one specific syndrome. This tumor type can be involved in different cancer syndromes. And then it's really important to know what kind of hereditary cancer syndrome is associated and the gene that is associated with this disease. I brought this study here just to give a little level of complexity in the identification of germline alterations. Well, in this study published in JAMA Oncology recently, 2022, they investigated 3 different cancer registry individuals that were sequenced, and then they identified 38 gene cancer associations and individuals from completely healthy individuals, or individuals that are part of one population-based cohort. They don't have a hereditary cancer syndrome, but they are part of the population study. And then the authors described 38 gene cancer associations, but not necessarily with cancer, but also with non-neoplastic diseases. What it means? Sometimes you have one gene that is related to breast cancer, just like BRCA1 and BRCA2. They identified the same variant in high frequency in different databases when they investigated the cohort evaluated by genome sequencing. And then they demonstrated the presence of the variants that already was associated, for example, with breast cancer, with no malignant disorders, for example, ovarian cysts, or multi-age with polycystic ovarians, or deficiency of vitamin D in patients with BRCA1. What means that sometimes the patients of the general population can have some non-neoplastic disease, can present a variant, germline variant associated with the risk of cancer, but they can develop not the cancer, but different phenotypes, just like ovarian cysts, for example. And then this is a very interesting results, because sometimes you don't know the origin of this ovarian cysts, and this could be also alteration that predisposes to subsequently the patients develop ovarian cancer, for example. And then this is a very interesting result. So when you saw that germline variants can contribute not only to the risk of cancer, but also to the different phenotypes or different tumors, when the people, when the literature doesn't know exactly what these genes are associated. And this study, the level of complexity increase. It's because recently they discovered that some patients, when they did the sequence of a tumor and blood parity samples, they found some susceptibility genes associated with cancer, having the alterations in mosaicism. What means that they have a population with the pathogenic or likely pathogenic alterations, and some populations, they don't have the same. They confirm these alterations in different tissues, and they confirm that these variants are really in mosaicism in those individuals. And this has a strong impact, because sometimes you don't identify some variant associated with the risk of cancer, but they can be there by mosaicism, and the protocol that you use it to identify these alterations is not enough to identify the mosaicism. This is a additional level of complexity in the study of germline alterations. In addition, we have a solid evidence about the role of germline variants in the risk of cancer development, not only in hereditary cancer, but also in different phenotypes. This is some papers that I collected just to show that the role of germline variants have been densely studied in the last few years. And then we are discovering not only the role of these germline variants in the risk of the disease, but also that some germline variants has impacted as a drug, as a therapeutic target for the tumor. This is a huge information and very important data when you identify a germline alteration that can be used as a marker to treat the patients better. And then based on this introductory part of my talk, I will show some results of my group. This, I selected one group of patients with rectal cancer. The patients were selected from Asa Camargo Cancer Hospital, and the rationale behind the investigation is the increase in the incidence of not only rectal cancer, but colorectal cancer in adults, younger adults in worldwide. Então, what you have is a number of rectal cancer patients present an increased risk to appear at age around 60 years old. But we have a group of cases of patients aged 25 to 49 that present a high risk to develop cancer and present cancer, and you don't know exactly why they have this cancer. This finding is observed not only for rectal cancer, but for colorectal cancer in different studies in the literature. This is the second cause of death in men under the 50 years old, the fourth cause of death in women at the same age, and the incidence could be observed here. This is the high risk of the disease in ages before 45 years old. And the main tumor type responsible for this increase in colorectal is rectal cancer. Well, and then this is some impact that we should discuss. The first is when the patient is young, with age before 50 years, under the age of 50 years, you need to think about that. This age, the patients can present fertility, is the age of fertility. And then when you have a patient with 20 or 30 years old, you has a tremendous impact in the fertility of these patients. And also, I think not only the fertility, but when the patients with less than around 30 years old is treated by cancer, they can improve the risk to develop, if he survives, improve the risk to develop a second or a third or a fourth primary tumors. This is not a isolate case when you saw this finding. It's in general, the patients with disease at early age is very common that they have multiple primary tumors. And also, in general, the presence of one young individual with cancer shows that the family can have more patients at the risk to develop the disease. And also, it is really important to know that these patients that were treated for radiotherapy or chemotherapy, they have late morbidity. They can develop cardiovascular diseases, among others. And in addition, it's it's some kind of discussed in the literature that a group of patients that present the disease at young age, they can have a very aggressive disease. And in fact, in rectal cancer is very discussed at this point of view, mostly because some patients is misdiagnosed. They don't believe that a patient with 20 years old has a rectal cancer, for example, and then they treat it just like something else, but not like, they don't go ahead and to confirm the diagnosis of cancer. And then the disease can be diagnosed later on the life, and then the diseases progress and it's more aggressive. What could be related to this phenotype observed in patients, in young patients. Although today, the doctors have been advised about the risk of the disease at young age, and the diagnosis it's improving in those patients. And then what you did is collect 71 unrelated patients with rectal cancer. Well, I did inform you, but the risk of young patients to develop cancer have been associated also with obesity. The dramatic impact or increase, the dramatic increased number of cancer patients at younger age was related to the weight at diagnosis. Most of them are overweight or present obesity. And this is a really important thing to discuss and to better study, to try to change the phenotype of our population, the population in general, that are weight a lot in the last years. We have a significant number of overweight individuals in our group of cases. And also they have, most of them don't use tobacco, but they are drinkers, or drinkers. They don't drink and they don't smoke. We have a significant number of patients that follow criteria for hereditary cancer syndrome. This is the reason why you selected these patients. 21 follow the criteria for Lynch syndrome, and 55 patients had at least one family member with cancer. All of them had the age from 22 to 40 years old. We did the target next generation sequencing in 93 genes, and from this gene, 13 are involved in the homologous recombination pathway, and 5 is from mismatch repair, MMR genes. Next, we evaluate these variants, and we select some individuals, index cases, and also relatives from the 10 families to confirm the variant found in next generation sequencing. This is our findings, but I will explain a little bit more details. We got 16 of 21 patients with Lynch syndrome present at least one germline variants. Therefore, we confirmed that patients, young patients that present clinical phenotype of Lynch syndrome, 16 of them present the germline variant that explain the phenotype. 13 of those patients present variants in mismatch repair genes, these genes here, or in genes related to homologous recombination pathway, including BRCA1 and BRCA2. 5 of these 16 patients present variants in genes, in other genes, in more than one gene involved in DNA repair. 3 of 16 patients present variants in different genes, and 5 patients had no variants. And 3 of 8 patients with no clear clinical criteria of Lynch syndrome also present variants in DNA repair genes, confirm that they are really Lynch syndrome patients. Most of patients present the moderate, present variants in high or moderate penetrance with pathogenic or likely pathogenic classifications. This is the number of patients with high penetrance, moderate penetrance, low penetrance, and some no classified. And this is the genes involved in pathogenic, likely pathogenic variants of uncertain significance. We also found an association between mismatch repair genes and the obesity. Patients with mismatch repair genes present the high risk, present an association with obesity. This is just a finding. The number of cases is not too high to conclude, but there is an association that should be discussed and investigated better. We confirmed the variants detected in our index patients in family members. In most of cases, we are able to confirm the presence of the variant. These three individuals, the brother, the sister, and the niece, not affected by cancer, presented the same variant that the index case, for example, for this gene. And here also, we found 2 patients that present the same variant, 3 patients that present the same variant that you observed in our index case. This is the Sanger sequencing when you confirm the variant using the segregation analysis. And also we compared our data with the 5 studies that use the gene panel or whole exome sequencing. This study presented the 151 rectal cancer patients. And then we compared our variants with them, and then we found at least 3 genes that is commonly altered in all data sets, including ATM, APC, and MSH2, in different frequencies, but at least ATM is the same. In conclusion, this study showed that 44% of your variants occurred in genes associated with cancer predisposition, this one, and 17 in genes associated with colorectal cancer. 32% of the patients presented pathogenic or likely pathogenic variants in our data set, and 16 to 18% in the other studies published in literature. In summary, what you find that is the genetic counseling and genetic testing is an option that should be considered for all patients with early onset of rectal cancer, mostly because the frequency of variants that explain the phenotype is really high. And then it's not by random. Apparently, this cancer is not sporadic. Most of cases present some variants that should be diagnosed and also involved or investigated in the family members to try to better treat, or also to treat early the patients affected by the mutations. And this study was recently published in Cancer Communications. I appreciate the help of my students involved in this study. The second study that I want to discuss is a group of patients with head and neck cancer. Head and neck cancer is a very common disease around the world. It's the sixth most frequent malignancy worldwide. But in young patients, they represent around 8% of cancers. And in this study, they evaluated more than 400 individuals, and they demonstrated that disease is more frequently observed in female than male individuals. We collected our cases also in Brazil, in a Camargo Cancer Center, in collaboration with Luiz Paulo Kowalski, my colleague for a long time. And we selected 30 paired samples from oral with oral oropharyngeal carcinomas, and also paired with peripheral blood lymphocytes, and an independent set of this first one of 15 cases when you have 10 blood samples and 5 tumors of the same patients. And then you run roll exome sequencing in all of these individuals, and you will compare our data with the TCGA and head and neck from the TCGA in patients of the same age, under the age of 49 years old. We had as one of our exclusion criteria was if the patient was previously diagnosed with Fanconi anemia or dyskeratosis congenita, we did not select these patients. In fact, none of them fulfill the criteria for those both syndromes. We excluded these syndromes because both of them are related to high risk to develop head and neck cancer. This is our group of cases. We have, as I told you, 45 individuals, and then what you observed in this cohort is that although they don't have the smoking history, or some has, no, the majority don't are smokers, but in the opposition, most of the patients are drinkers. They used to have a high consumption of alcohol in both data sets. Well, this is young patients, and then it's really important to say that smoking habit has been debated, and then there are a lot of people that stimulate the young patients don't smoking, but the alcohol is increasing tremendously. And then it's important to observe that at least more than 68% of patients from this group, 62, 69, and 66% of patients, around more than 60% of them are alcohol consumers. When you saw this cohort of patients that you analyzed, it's 45, you can think, well, the number is too small to find something else. But when you check the TCGA, the entire TCGA has approximately 10% of the patients has less than 49 years old. Yeah, is the number of 55 individuals. We have 45. And then we also have the HPV, alcohol, tobacco, and HPV are the 3 most common etiological factors associated with the risk of head and neck cancer. We did the sequencing in the germline and evaluated the blood samples from both cohorts and also the tumor of both cohorts. And then when they investigated the frequency of the variants found in both groups, we observed that FAT1, FAT1 are observed in higher frequency in both data sets as a germline alteration. And the TP53 was the common gene associated with alterity in the tumors. It's interesting to discuss that 7 of 45 patients present germline variants in FAT1 gene. This variant was also, this gene was also investigated in the tumor samples, just like variant or copy number alterations in both data sets. And we found only one case when you have loss in both the normal and the tumor. The second event appears just in this case. In the other ones, we have only the germline alterations or the somatic alterations. Somatic alterations have been discussed frequently, not frequently, but has well discussed in the literature. What you found is that when the patients present the germline variants in this gene, we have a shorter survival in those patients. The mutant, the variant, are associated with shorter survival. And the literature shows that the alterations in this gene is associated with the poor efficacy of the EGFR or MEK inhibitors. And then the presence of these variants in the blood sample of the individuals can contribute to identify the patients that can present, that can be submitted to certain treatment or not. Although we exclude the patients with Fanconi anemia, it's keratosis congenita, we found patients with mutations in those genes. I am showing here 3 genes that present pathogenic variants and 4 genes that present variants in 6 patients. Both of them don't have the classical phenotype of Fanconi anemia or this keratosis congenita. Well, what this finding means, no? It means that sometimes you don't have the total expressivity of the syndrome. You can have some symptoms, but you don't have the patients don't fulfill all clinical criteria for the syndrome. But even that, they can present the gene mutated, and then they can have the risk to develop the disease. This is the case of those patients. And also we found the genes previously related to head and neck, just like CDKN2A and REC-QL4, that were previously described in a paper published in GCO Precision Oncology. And we found also this GBA and other tumor suppressor genes related to other syndromes like PTEN or RB1 related to retinoblastoma mutated in our patients. And the GBA was recently described in a study with more than 10,000 individuals as a driver related to their risk to develop cancer. And 3 patients present some gene, WRN, that is involved in the stability of the genome, DNA repair, replication, transcription, telomere maintenance. And these patients presented these mutations, and this gene have been associated with a response to therapy to irinotecan. And then sometimes it's important to know, because you can decide the better therapy for the patients present some kind of mutations. We also compared the profile of the variants in DNA repair genes with the survival. And then we found some relations, although the number of the patients is too small, but we can observe that there are some associations or some trends to the shorter survival in patients with those alterations. Well, when you have a mismatch repair or homologous recombination gene is mutated, you can have a deficiency in the repair. And when the system is altered, you can have a hypermutant phenotype. And what it means that the tumor can improve or can have a higher number of somatic mutations. These tumors, in general, could be driven by smoking, for example, just like head and neck, lung cancer. They are hypermutant cancers because they have a high number of multiple somatic mutations. In general, these hypermutant cancers respond better to immune checkpoint inhibitors. And then there are some that are approved for head and neck cancer, and they have been tested, and what they found in the clinical practice, only a minority of those patients present good response to this immunotherapy. In my opinion, it's just because you just don't select the patients according to the genotype that they have. I think it will be really important to identify the germline variants that this patient has, because it's possible to identify the right patients that could be better, present a better response to the treatment. If you have some MMR mutations, you can have a response to the treatment, to some immunotherapy. And if you don't have, perhaps you don't have the better response to this treatment. We also identify when you did a network grouping or somatic and germline alterations. Interesting, we observed the TP53 as the central node in this interaction. A new study published recently in solid tumors from young patients, they present the same pathway alterity as a central node, involving all genes related to observed in the group of patients. This is a huge number of individuals tested, and the TP53 was the central, just like yours. In conclusion of this head and neck study, we had 12 patients that presented no clinical features of Fanconi anemia or dyskeratosis congenitis that present variants in genes related to those syndromes. Variants in the DNA repair genes like MMR and homologous recombinations are actionable targets for therapy. 53 signal pathway appears just like a central node, a central pathway in cancer predisposition. And FAT1, as I told you, is a germline variant. It was associated with head and neck cancer, and this probably could be used as a predictive marker. This paper is also recently published. This is the view that I have from my house. This is a forest in the autumn. This is the view of my home. Thank you so much.
Thank you, Professor Regina Rogato. It was a pleasure to hear you this morning and having this so exciting data you brought to us. I invite the audience to post their comments or questions in the chat box, so don't feel shy, and come on, make your questions. Of course, you have a lot, but while the audience come with their comments, I have some questions that came from some comments you made during your presentation. For example, you showed that several germline variants to FAT1 in head and neck cancer. And my point is, to which extent do these germline variants explored have a functional role? They all alter the gene at the same extent, or they may produce different functional effects on the gene expression?
Well, we found not only one. I'm not sure if I understood well your question, but we don't have some hotspot mutations.
Yeah. Okay.
And FAT1 gene. Just like the literature said, this gene is, we involved in several exons involved in the mutations, but also I not explore exclusively the mutations, but also the copy number alterations. A recent paper published in Nature just describing the role of FAT1 gene in the cancer showed similar data. They present some copy number alterations that alter the function of the gene, and consequently, apparently, they can be used as a target, for example. This is a one finding in FAT1. It's interesting because it was the most frequent alteration that I observed.
Yeah. So, and do you think that environmental factors could superimpose a regulatory activity on these targets? See, my question considers what is showed to head and neck cancer, and also considers that cancers are most environmental, 90 to 95% of cancers, than inherited. Yeah. So do you think that these environmental factors superimpose these inherited alterations you showed?
Yeah, well, for example, if you think about the colorectal cancer, the rectal cancer that you study, a set of patients, although they are young, they have the tumor at ages not completely expected. They don't have any mutations, but we have limitations. We did not investigate the full genome.
Mm-hmm.
And we not evaluate the methylation status of several genes related to the disease, And then, a set of patients you cannot explain by the presence of germline alterations, but they can have some environmental effect that increase the risk, or the microbiota. Today, the people are talking a lot about the microbiome changing the microenvironment and increasing the risk to develop the disease. We cannot just put our eyes in only one event. We can open your mind and think, okay, I had no idea that we can have actionable mutations in germline variants. No, that I had no idea that you can observe that. And now you know that you can detect it. And then you know that you can detect the alterations and germline alterations related to the cancer that in patients that you don't expect because they don't have a family history. They are completely control individuals. How they have some mutations related to the risk if they don't have nothing. They are really sporadic cancer. This is our question now. Perhaps our genome has much more information that will allow us to identify that the frequency of sporadic cancer is not too high as you think. No,
indeed, we have a very long way ahead.
And then also you have clues to treat better our patients if you know better what's going on with the genome of those individuals. I think always you are studying, you are learning more, and different levels of complexity. And then, you can do the sequencing, but a few years ago, or just a few years ago, you don't know, you don't have an exact pipeline to investigate the copy number variations. Today you have. You can use both when you do the sequencing. And then you can have some certainty about the region if they are altered by one or other mechanism.
Yeah.
But for sure, this is not enough. No, you have much more. No.
To explore, that's true.
Yeah.
Come on, the audience is not manifesting anything. Okay. To finish, I'd like to know that at the beginning of a presentation, for instance, you said that the identification of somatic mutations open a perspective for drug development. I mean, when you have an alteration, that is a perfect target to be modulated.
It's exactly what the people are doing now, no?
Yes, that's it. Well, target therapies. But however, for germline mutations, it is somewhat hard to do, mainly because all cells in patients' body will present the modified target. So,
but it's a usage. If you saw about the BRCA1 and BRCA2, they use PARP inhibitors to treat those patients. They have the ovarian cancer, for example. If they have mutations in BRCA, they give some specific therapy because they have the germline alterations. For sure, you have the mutations in the entire body of the individual. It's expected.
Yeah. So developing a drug, it's considered that altered gene maybe could be a strategy, but also investigating the disturbed pathway would be also an alternative strategy in those patients with germline mutations, isn't it?
Yeah, for sure. To evaluate for example, I always thinking why the TP53 pathway that I found as a central node, groups all germline and somatic alterations, just like a central. For sure, there are something in those patients that, independent of the variant, the pathway is the same.
The
pathway is the same. True. And then perhaps you needed to find a solution to identify who you need to attack to get a better result from these patients.
That's true. That's the way we call precise medicine, that investigates the specific alterations a patient have, and compare it with other patients. So a specific strategy must be delineated to that individual specifically. So, Professor, thank you so much for your attention. The audience
thank you,
message, but
thank you, Roberto, and thank you everybody to be here. I hope that I was clear.
For sure, and a really nice data you brought to
us. It's important to participate, but sometimes they are shy. But you can speak in Portuguese for sure. I can answer
Great. So thank you so much. I thank you, the audience too, for attending. And Gabi, we can finalize this section.
Yes, we can finish. You can feel free to go. Thank you again, Professor Regina and Professor Roberto.
Bye-bye.
Thank you.
Bye-bye.
See you, Sylvia.
Bye.
Thank you again.